Hi, I'm Kyle, and today we will be talking about tips for ultrasound-guided thoracentesis. So what are some of the benefits of doing a thoracentesis under ultrasound? Thoracentesis itself is a relatively safe procedure, so what are some of the added benefits of ultrasound? Well, ultrasound is confirmatory in real time, and with this you have improved safety and lower complication rates. For a thoracentesis, the major complication would be pneumothorax, which would be reduced with the guidance of ultrasound. So with any procedure, one of the most important things is patient positioning. If the patient is able to, have them sit up on the side of the bed, kind of leaning over a bedside table, and this would give you a good view of the posterior thorax. However, this is not always the case. ICU patients, intubated patients, and those coming in ER with trauma will most likely be supine. And with this, try to get the arm out of the way of the lateral thorax if you can to give you a better view of the area that you'll be working in. So the next step would be ultrasound probe positioning. Use the kit provided by your institution. Get your probe covers, sterile probe covers on with a sterile field set up. Kind of mark your landmarks on their lateral thorax and get ready to kind of start to visualize some of the landmarks in the lateral thorax. For example, you can see some of the visceral pleura in the lung, the diaphragm, and the rib in this picture. And with the picturing of the rib and the rib shadow, it gives you an idea of where the inferior rib would be with the associated intercostal artery that you want to avoid. So now that you have your ultrasound on the patient, you're identifying some of the landmarks. You can see the pleural line at the top of the screen with the ants marching along the log, signifying good pleural sliding. You see a lot of free fluid in the thoracic cavity. You also see the collapsed lung parenchyma kind of at the bottom left of the screen, floating in the free fluid. You can also see the echogenicity of the diaphragm, and this picture is of the left upper quadrant, but this located under the diaphragm would be the liver or spleen. Now when doing your ultrasound, you've identified that there is a pleural effusion, and to estimate how much free fluid there is in the thorax, one thing you can use is something called the Ballig formula. Also, the max distance between visceral and parietal pleura measured in millimeters, sometimes called the PLD, can be used, and with that measured distance you multiply by 20 to kind of estimate how much effusion volume there is. So again, when diagnosing pleural effusions, you're in the coronal plane, kind of in the area in this picture in the right upper quadrant. You can see the diaphragm, the liver, and you see the lung parenchyma moving in the free fluid. So now that you've diagnosed your pleural effusion in the coronal plane, to use the Ballig formula, you're going to rotate your probe 90 degrees with the marker pointing up, and you're going to get the same view but now in transverse, and this will kind of give you the idea of where the posterior chest wall is and where the base of the lung parenchyma for your measurement. So we have our probe in transverse, we've freezed the image on the ultrasound, acquired the image, and now we're doing our measurements. You take the posterior chest wall, you take the lung base, and you get the measurement of 15 millimeters. Using the Ballig formula, the 15 millimeters times 20 gives us an estimated pleural effusion volume in this patient of around 300 milliliters. So where you want to insert your needle is kind of where you had your ultrasound probe to get the image. And if you're doing this dynamically, you'll see the needle tip go through the soft tissue, the intercostal muscle, and then you'll find the needle tip entering the free pleural fluid there, avoiding the diaphragm and avoiding the lung. So this is an example of a dynamic ultrasound inserting the needle below the ultrasound probe, and you can follow the needle tip as it drops down through the intercostal muscle and enters the pleural free fluid there. It's starting to drop. And then that way you can track yourself as the patient's breathing to avoid the lung and avoid the diaphragm, but again, you've already measured the distance between the muscle and the lung and the muscle and the diaphragm, so you'll know how far you can insert the needle. So for follow-ups on patients, you want to do an ultrasound. You want to do a pulmonary ultrasound looking at pleural sliding. Here you can see the pleural sliding pretty well. You want to make sure that it's sliding to avoid pneumothorax. You want to make sure there's no B lines, any signs of pleural effusion there, which can be complications after a thoracentesis. And there it is again with the pleural.